working here, being able to save someone else's sister or someone's daughter. It's a dream come true. For me. Anyway, so, how can I help? Sorry, that's not a trick question. I'm really just asking. I work for you so you can work for your patients. How can I help? Just shout it out. Really? No one? Wow. Okay, why don't we try this? I'll go first. Will everyone in the cardiac surgical department please raise your hands? Don't be shy, just get them up there. Great. Great, thank you. You're all fired. Any department who places billing above care, no matter how much money you make this hospital, you will be terminated. Oh, I am serious. Bye-bye.
Serious?
We're gonna be starting over, all right? Without you. Sorry. Next, will all the department chairs raise your hands, please? I have no idea how you managed to keep this hospital afloat with so little help. So I'm gonna hire you 50 new attendings because untrained residents will no longer be running this hospital, regardless of how much money their university makes off their indentured servitude or how much time it affords some of you to play golf. So, let me ask again. How can I help? Yeah, person not calling their lawyer.
Lauren Bloom, emergency department. I want to get rid of our waiting room.
Okay, where do you want to put it?
I want to get rid of it. I want to move patients direct to bed, no waiting room.
Done.
Really?
Sure, let's try. Yeah.
Hi, Dr. Iggy Fromm, head of psych.
Can we do something about healthy food?
What do you want to do about it?
Have some.
Chewy, in the hospital.
Okay. Done.
Aces. Thank you.
Thank you. You know, we all feel like the system is too big to change, but guess what? We are the system. And we need to change. So just tell me what you need, what your patients need, and I don't care if it's not covered. I don't care if the board said no. Let's get into some trouble. Let's be doctors again. Okay, I appreciate it. Go and I'll see you out in the wards. Thanks.
The medical drama New Amsterdam features Dr. Max Goodwin as the new medical director for one of America's oldest public hospitals. Max strives to do something that seems oddly revolutionary: put patients first. Among his first acts to impact patient experience are to eliminate the emergency department waiting room and to bring healthy food into the hospital. Throughout the series, he attempts radical changes to help patients have better experiences in the hospital and better health outcomes. But improving patient experience doesn't have to start with firing entire departments or upending every single process in a hospital. In fact, it begins with simply how patients are treated by healthcare professionals. Communication and empathy are building blocks to a better patient experience, says Dr. Rachel Hitt, and as the medical director of patient experience for the Tufts Medical Integrated Network, she's championing a different approach to patient relationships. This week on Next in Queue, we discuss why the relationship with patients is crucial in medicine, how business practices often create barriers in healthcare, how technology can both help and hinder patient interactions, the essential skill to delivering difficult news, and how active listening can improve patient outcomes. Let's get to it.
Welcome to Next in Queue, the podcast for contact center and customer experience professionals. Next in Queue is brought to you by Happy 2 Vision. Eliminate blind spots and see right through every conversation with Happy 2 Vision. Learn more at happitu.com. Now, here's your host, Rob Dwyer.
Welcome back, everyone, to another episode of Next in Queue. Today, I have got a very special guest, Dr. Rachel Hitt. Dr. Hitt, how are you today?
I'm great, thanks. Thanks for having me.
So give us a little bit of information about what you do today, and then we'll get into kind of the topic at hand. But you've got a rather long and prestigious title. Tell us what that is.
Well, I am the medical director of patient experience for the Tufts Medical Integrated Network, which is the Tufts ambulatory healthcare system here in Boston, Massachusetts. I'm also a clinician. I'm the chief of breast imaging for Tufts Medical Center in Boston as well.
See, that's a lot. Do you struggle to introduce yourself on a regular basis? Are you like, there's a lot going on here, it's way too long? Maybe we
the title is too long. So I usually say, well, chief of breast imaging and medical director of patient experience for the Tufts Health System ambulatory. So it's just, healthcare is always changing, always new names, things of that, mergers, things of that sort.
Yeah, absolutely. Well, I brought you to the show today to talk about patient experience. And so that's what we're going to get into. But before we do that, when we talked earlier, you told me that originally you didn't want to be a doctor. Tell us about how you ended up here.
Oh my gosh, I can't believe you remember that. Well, yeah, I think, at least in my family, being a doctor was probably, they thought I should be a doctor since I was born, that kind of thing. Like, oh no, that's not necessarily what I want to do. I want to make sure I chart my own path. And so I actually started out creative writing and studio art in college. And then I happened to take a human biology course and fell in love with it, like just human physiology and the whole thing. I loved it, but I still wasn't convinced I should be a physician. I certainly didn't tell my parents I loved it. And then I tried a whole bunch of other careers or things. I tried things out. I made sure it was what I wanted to do. I taught, which I loved to do in a high school. I did some basic science. I did some administrative stuff supporting my college as an admissions officer. I loved that as well. And then I kind of realized, no, I kept trying, I kept doing experiences where I'd be working with doctors. So I worked on an island in Maine with a doctor one January term during college, another time in the summer. And I did as many internships and exposure as I could. And I just fell in love with it and read books. And William Carlos Williams inspired me, and John McPhee inspired me to do medicine. So it sort of worked out. And then I was also really interested in public health. So I was fortunate enough to combine a master's in public health from the University of Michigan with my medical degree from Harvard. They allowed me to exchange the credits. So I got really lucky and it all worked out. Things always work out the way they're supposed to.
Yeah. Do you have a favorite William Carlos Williams poem about medicine that particularly resonates with you?
I am not a poetry girl. I am a nonfiction novel. He's got, so Heirs to General Practice was my McPhee one. And then Doctor Stories was his book that really inspired me. And in fact, that's the one I kept on my desk all through medical school. It was really
I don't know that one, but I'm going to have to check it out.
Well, I'm sorry, I don't know the poems as well. I'm a very concrete thinker, and poems I don't quite get. Maybe that's why I switched
very interesting
to medicine. That's probably I figured out what my strengths were.
That is funny. Well, let's dig into patient experience. I think all of us, once we reach a certain age, we've been to the doctor's office. Maybe we've been to an ER or we've been to a specialist. And so we've all got these experiences. What drew you to patient experience?
Well, what's always drawn me in part to medicine wasn't just the histology, pathophysiology. It was taking care of patients. This is a really sacred job that we have and the kind of relationship you can have with patients. And I think watching both my grandfather and my father were physicians. My grandfather was an OBGYN in a small town in Maine and really delivered everyone in town. My dad was a pulmonologist internist at a large academic institution, urban setting. But they always, so I always went with them on calls, and well, not necessarily calls, but I'd be walking with them through the hospital or just hearing about their patients. And they always had such a nice relationship with their patients, and it was always so important to them. And for example, my dad would have the patient come into his office, and across the desk, you would do your history. You would find out about your family, you'd tell them what your aches and pains were, and then you would get up as a patient and go into the exam room, and then that's where the physical exam happened. And I just heard stories. I just loved hearing about things. And I think just here, it rubbed off on me and how they treated people, even when we were just walking around the hospital. I think it really came across that the patients were it's the people. It's not just the medicine. It's the people behind the medicine. And then in my position as a breast imager, often I'm changing people's lives forever, and it's not lost on me. And I think it's really important to be there for people, to use our knowledge to help them. And even if it's not a cancer, people are scared. They all come in, they all think they have cancer, and how to navigate those waters. And it's just, I don't have many skill sets, but this is one of my skill sets. And so I'm happy to share it.
Well, I think you're probably being very humble about saying that you don't have many skills. I imagine that is not true. But let's talk about some of the barriers to delivering a great patient experience. Certainly you mentioned one, and that is maybe that just the patients expect the worst sometimes, but I don't think that's the biggest barrier. What are some of the things that you see that are big obstacles that you're trying to overcome?
That's a great question. And I think I would love to practice medicine the way my dad and my grandfather practiced. But the business of healthcare is completely different from when they were in practice. So I think there's a lot of, one, you have volume. There are more people in this world. Granted, there are lots of doctors, but are there enough doctors? Are there enough clinicians? So, you've got nurse practitioners, PAs, it's growing. Everything's growing. Are we able to train enough physicians? Not necessarily. We keep hearing about what's coming ahead and how we have to prepare for it. But just on the day-to-day basis, it's the business of healthcare really gets in the way. You're constantly being asked to produce more at a faster time and a faster rate. I think the element of the computer, although it helps us in many ways, it can slow us down in other ways, and it detracts from the personal interactions. As you know, in a primary care setting, the doctor might be entering things on the computer, not being able to look at you and listen to you. And it's just normal common sense. Like, how do you interact with a patient? We're having a conversation more or less face-to-face, granted through a computer, but that makes a big difference versus me looking at the computer, focusing on that with the extra added pressure, having to see a lot of patients. So I think, and then there's the administrative burden, all the charting, all the prior authorizations, people trying to hit their deductible, their insurance. So there are a lot of elements to it that make it very difficult. Patients not getting their care because they don't have the insurance. My mind's just wandering, but I think there are a lot of man-made barriers to the normal, natural connection that people have when you're trying to take care of each other.
Yeah, absolutely. I think many of us have had that experience where we don't feel like, maybe we don't even feel like we're being listened to in a doctor's office, because there is that need to document, to look up information. And so there's less of that just active listening and more I'm digging into some other things while I'm listening. And that certainly, when I think about a lot of times on this show, we're talking to people who are in other types of service, right? Not healthcare, but if you're calling me about your lost package and I don't sound like I'm paying attention, right? You're probably going to get a little upset about that. And the stakes are wildly different when we're
Mhm.
talking about a lost package versus something that's impacting my personal health or my child's health or my spouse's health or my parents' health. So I can understand why that is a huge, huge challenge. Are you finding that you mentioned technology can be a barrier? Do you see technology maybe stepping in to kind of help some of those things? So one of the things that I'm thinking about is the note-taking aspect. Are there ways that we could automate that so that I can, as a doctor, as a physician, just pay attention to my patient?
Yes, that's exactly what I was thinking. But first of all, I think all physicians still want to have that relationship with their patients, or most, I'd say the majority. I mean, that's what brought us into medicine, and not just physician clinicians. I think that's the goal. I think we're just got so many distractions and access and things of that sort. But yes, in terms of there's roles for AI, there's note-taking things where they can listen to the ambient sound and miraculously sort of pick up what's important, what's not. I don't use that in my setting because it's different for what I do, but I've heard about that in other situations. Again, there's a cost involved with all of this.
Mm-hmm.
And so that's, I can't even speak to that. And now financial institutions are having a lot of issues. Healthcare institutions are having financial issues, excuse me. So how to get that software that we can pay for. There are a lot of needs of these institutions. Where do you prioritize? But yeah, I think we can certainly, I'm not trying to sound like I don't enjoy computers. There's definitely need for computers, access, you can see what's going on everywhere. It really helps a lot. But at the same time, how can we utilize the computers to our advantage, to use them the best
Mm-hmm.
rather than a disadvantage?
Yeah, I mean, we hear too about these hacks of healthcare systems, and that's another place where I think computers, while they provide great advantages, they also open up the healthcare system to some risks. And I don't know that there's a good way to fix that, right? I don't think we're ever going back to just putting everything on paper,
No.
but it does create an additional barrier when potentially I need to go see my provider and they can't access my medical records. That's a challenge that I don't know that the system has confronted or created solutions for. Do you have any thoughts on that?
Well, in my world of imaging, we are actually pretty good about getting outside images. It can take some time. There's a lot of computer buttons that are hard that you need to push and things that people you have to talk to, but you can eventually get them. Not always, but sometimes. So it is a challenge. But I always tell patients, if you go from one place to another, bring your record with you, bring your images with you so that you can have that information. So it might be hard for an institution to do. You have to sign a report, and then just getting information can be hard. Take the ownership of bringing stuff with you and then providing that. And you just have to.
Yeah, that's great advice. So, while we're on the subject of technology, I actually saw a recent post on LinkedIn, actually just this week, and it made me think of you, and I wanted to bring it up. And one of the things that we're seeing is there are all kinds of apps where I can access my patient records, right? And so, if I've got test results or even interactions with my physicians, I can have that inside an app. But I saw someone post about an app that they use to check in when they go to their, this is a primary care group, and it has ads in it.
Really?
Yeah. And so the ads, one of the ads, she detailed two ads. One of the ads was for a different brand of medication for a similar condition, a medication that she was already on. And the other one was for a Find a Doctor website. And she questioned
Really?
whether or not she should be finding a doctor. But I wonder what your thoughts are. You mentioned financial challenges, right? So I know that right? Every business is always trying to think about how do we generate more revenue to balance the books. What are your thoughts on that kind of way about monetizing?
Maybe I'm a purist, and on first glance, without knowing all the numbers and things behind it, that's not how I would want to conduct business for myself. I feel like you have to stay sort of neutral. We are providing a healthcare service, and I think it's important to keep that so nobody has, even if it has nothing to do with how you treat a patient, we don't want any sense of impropriety or any sense of undue influence. So I think it's really important to just stay very neutral, stick to the business. It's you and the patient, and that should be all that's visualized in that website. That's just my feeling.
Yeah. No, I'm with you. Call us whatever you will call us, but I am with you. And by the way, for anyone who might be listening, considering that as a strategy, let me tell you, the person who posted that was very upset about it. As she said, irrationally angry about it. I think it was probably...
That's never the goal. That's never the goal.
No. So let's talk about delivering bad news, because I do think that is maybe one of the most impactful parts of patient experience, or not necessarily bad news, but challenging news. Where do you just tell me in general what your thoughts are about that?
Well, you touched upon it earlier in our conversation about active listening. And I think these are skill sets that we can train each other. Clinicians can train each other how to do it. And also we can use it for anyone who touches the patient on the patient journey, the front desk, environmental services, food industry, food aspect of it. And also, so there are three parts. And I learned these skills from the Academy of Communication and Healthcare. One is sort of establishing a relationship, creating rapport. And your smile is your superpower. And it really, we're humans, we're designed to appreciate people who smile. It makes us, it's warm. So just smile. Even during the pandemic, when we had behind masks, you can tell when someone's smiling and when they're not smiling. You're talk to them, just say hello, just acknowledge them. Basic common interactions is so important, showing that you care. And that takes seconds, really. It doesn't take long. As humans, we make judgments about people within the first 30 seconds. Are they grumpy? Are they helpful? Are they friendly? Are they going to not be interested in what I'm saying? And then so I do teach clinicians how to do this. The active listening is how to sort of elicit their needs, elicit their list, find out what's important to them without interrupting, and just without going down rabbit holes, getting those things, and then negotiating the agenda with them, figuring out what's important to them, what's important to you, making sure you're both on the same page. And then after you've done your exam or whatever it is, how you communicate that information to people. So to make sure that they understand, meet them at a level where they are. So in terms of difficult conversations, I will never use the word cancer unless a patient uses the word cancer first. And I try to show them support, that I'm with them, because there's a way I could say, Mrs. Jones, there's something where you're feeling, I see that's worrisome. I want to do a biopsy. We're going to schedule that before you leave today. I'll let your doctor know. Okay. And then sort of walk out. And that's not effective, versus where I could break it down, say, when I feel it's appropriate, I could touch her, like depending on the situation, like usually I'm in the ultrasound room. Just say, Mrs. Jones, what you felt, I actually see something. I'm a little worried about it. And then you have the power of the pause. Let that sit, because I just threw a bombshell on her. I just changed her life. She's really thinking the worst situation. And then I can let her respond to me, and then I can respond to what she's saying. And if I can say, have you ever had a biopsy before, a breast biopsy before? No, I haven't, and I'm really nervous about it. I understand, and then I respond and support her, say, I understand that. And I figure out what her concerns are, and I can relate to that. But at the same time, I'm getting the information out that I need to have this done, but I'm figuring out what concerns her the most, and I'm answering her questions. And surprisingly, when I tell people I'm worried about something, a lot of times, they're worried about things I wouldn't think to be worried about. What about the numbing medication? Am I going to get a lot of numbing? because they're processing where they are, and I just have to meet them and tell them. And I will be as honest as I can be. If they ask me a question, if they say if it's cancer, I'll tell them I'm actually a little worried it could be a cancer, but I'll say I hope I'm wrong. And if I'm wrong, you can be really mad at me. So there are ways you can do it. And then if someone has cancer and they're going through it, you say, we're here to take care of you, because that's really what we are here to do. We're partnering. And I think that's what people are just looking for from everybody: support and partnership. And I have the medical knowledge, but also I'm a person. I know what I would want. And I think I'm just trying to give that to patients as well. And this is what I'm trying to teach other people.
You hit on three, I think, really critical things there that I want to touch on a little bit. The first one is word choice really matters. Can you talk a little bit more about that?
Exactly. So fundamentally, I'm thinking a couple of things. In my situation, talking about cancer, I never use the word cancer unless I bring it up because it's such a scary word. But then you also have to figure out their level of understanding. Do I need to bring in an interpreter? What do they know about health literacy? I don't want to talk jargon. You want to keep it pretty simple. Even when I'm explaining these kinds of things to doctors, I'll say to them, I know you're a doctor, but if it's okay with you, I'm going to treat you like a patient because that's how I want to be treated. I don't expect them to know about breast imaging if they're a nephrologist or a cardiologist. And I certainly don't expect them to be paying attention if I've just told them there's something I'm worried about. So I bring it down to a really basic, try to use non-jargon. So if I say something's benign, I immediately follow up, not cancer, because I don't expect people to know what benign is. And it's just that idea of word choice in terms of meeting them at their level and explaining to them in a way they understand, but also give the power of the pause and to ask questions and respond and then direct the conversation to where it needs to be. So what we call ART loops: ask, respond, and tell.
I love that. The one of the other three items that you touched on was getting the whole team on board, right? Our experience is not simply with our physician. And so that communication, in order for the entire team to respond similarly or in an empathetic way, I have to communicate effectively with all the members of my team. Can you talk about that and maybe some of the challenges that are involved with that?
Yeah, it's really hard. Sometimes you're in a really high stakes situation. There's a lot of pressure on you. There's a lot of volume. You have very high expectations for yourself. You have very high expectations for your team, and how to be supportive of them as well, so that when, let's say, the front desk person can be as kind and friendly with them as they are with each other, with other people. So how to do that. So part of this training, this active listening, is also for that group as well. And I think everyone, myself included, there are always ways to improve, You're always hardest on the ones you love. And so just that acknowledging and understanding the emotions that come at work and just appreciating that and doing these skill sets with each other. So we can't take care of our patients unless we take care of each other. And we need to understand that as a healthcare system, and that's a priority.
The third thing that has come up multiple times is just this idea of empathy and responding with empathy. And I hear you talk about this when almost in everything that you talk about in interactions with the patients. Can you talk more about that and how critical that piece is?
I think that before we go to medical school or training to be a clinician or whatever we do, we have that. We know what it's like to be the patient. We know what it's like to be the caregiver of a patient, have a loved one who is a patient. And then you go through training and I kind of feel like you lose a little bit of that empathy. I think schools now are trying very hard to remind people why you went into it, but you're trying to get through your day. You've got a lot to do on your to-do list. You have a lot of volume. You've got a lot to do, and you're trying to get it through the end of the day. And it's that trying to remember what's behind that work that you're doing, that constant thing. And I think in the busyness of the day, that can get lost. So if we can take time for ourselves, little reminders, and I think every time a doctor becomes a patient again, it's a great reminder. And so how do we recreate that? How do we remind people of that? And again, it's just, what would you want? This is, again, common sense. What would you want? What would you want your loved one to want, to have? And so how to explain that to them and remind them, how to do gentle reminders of that. Because we get busy in our day trying to get through it.
Absolutely. And I think a lot of us can empathize with that feeling, because we've all been in situations where we are kind of going through the motions because we've got things to get done.
Yeah.
And it absolutely, number one, can make someone feel like they're not heard or they're not valued, and that's not great for experience. But it can also lead to missing things and creating a moment where I've got to come back. Can you talk about how spending a little bit more time up front can save time on the back?
Exactly. So ultimately, I think if you do this efficiently, you're actually reducing the amount of time it takes to interact with the patient, because you're extracting much more information in a shorter amount of time. So, for example, if I start asking a patient when I'm trying to elicit the list of things that's going on with them, I'll find out what's going on. And if it's something that I can't help with, I'll tell them who to talk with. But in that conversation, as they're talking about things, I will find out information that I didn't know about that's really relevant. For example, their sister and their mother had breast cancer. So the strong family history, oh, I didn't know about that. But that's really important, so I can make sure they get a good elevated, they can figure out their lifetime risk of breast cancer. So you're going to get nuggets the more you talk to them. And it's funny, if you ask people, how long do you think a patient will talk until they stop talking? Like, you just let them talk and not talk. Like, that's one of my questions in my lectures. 5 minutes, forever, whatever. It's actually only 90 seconds. People won't talk as long as you think they'll. And the other thing is how often you think doctors will interrupt their patients before they start talking. And they say, oh, forever. That's like 11 seconds, I've read. So we're quick to interrupt because we're afraid people are going to talk forever, probably. But if we allowed them to talk a little bit more, they're not going to talk that long, we're going to get so much more information. You're going to, if you're in primary care, you're going to be able to find out the nuances of an issue. You can ask targeted, directed questions, but you're going to find out a little bit more. And you never know what little acorn is going to be left, and be like, oh, that helps piece it all together. So, and also it's nice for your relationship as well. So they trust you, and they're more likely to follow your recommendations for medicine, procedures, follow-up, if they feel like you're part of the team and you're there really listening to take care of them. So on the backside, you're going to get a lot of great return on this small investment.
Yeah, that's fascinating. The idea of just letting people talk. I think we've all been in situations where we are listening not to understand, but listening to respond. And we're ready with something that we want to interject. And we don't let people finish their thoughts. And we're going to miss something if we do that. And it doesn't matter if we're a physician or if we're working customer service or whatever it is that we're doing. Maybe we're hosting a podcast. I don't know.
You have a hard job.
People do more than just this. But it absolutely, if you're working and onboarding a new client, right? Sometimes you just need to understand more about a particular situation. Just let them explain everything that they're trying to accomplish and understand what obstacles are in their way. It's very similar. The stakes are different. They're vastly different, but the behaviors and the skill set of communicating, they extend across all of these different types of roles that people may be involved with. I do feel like, obviously, you talked a little bit about medical schools getting a little bit better about teaching empathy, but you've got some training that is for far more than just people who have gone to medical school. Is that a trend? I mean, are we seeing that in other medical organizations where they're doing this kind of training? Is it enough? Do you want to see more of it? What are you seeing there?
Always want to see more of it. I think that's pretty safe to say. We have great opportunities with orientations. We could do modules to remind people. So there's such a need for it. If we didn't need it, everyone would be happy going to our hospitals. And we know that's not the case. So even places that are doing really, really well, everyone could use some help. And I know healthcare needs a little help. So yes, I think there's a lot more room for it. I think the medical schools are doing a good job. I think there's room. I was talking to someone who worked in the financial industry who switched over to medicine. And when they were in the financial thing, he said, you bend over kind of backwards for the people to see what they need. And then she was surprised that we didn't do the same things in healthcare. It's sort of a different kind of relationship, and how important it is to remind us we're there to help them. We're still, versus us, we're doing them a favor by being their physicians or whatever, but it's a different kind of relationship. How can we help them? It's just the human connections as well. It's just that human interaction and how to get back to that.
Yeah, absolutely. I love that. What have we not talked about that you really want to share with the audience?
I think the future is bright. I think that we're going to be able to accomplish a lot. The more people come together, we need to make the tent even bigger. I think there are a lot of silos of people doing great work in this area. And I want to see this more higher prioritized as a nation. I think that'd be so important. I think this is just as important as quality and safety that you hear a lot about in healthcare situations. Because in the bottom line, this is why we all went into medicine. This is why medicine exists. We're taking care of each other. And hopefully I've emphasized that point, the importance of it. And I'd love to reach out to anyone who's listening to this and has ideas that I would not have thought about. And I think that's the best part, because I've been in my clinical lane for so long. But I know there's a lot of other great ideas, like even just what you were mentioning, like, oh, that's good. I'll have to think about that. The more people we come together, the better, because I think this should be a multidisciplinary approach to patient care and patient experience, and taking care of ourselves as well. There's a lot of burnout with physicians and the clinicians. I don't want to keep talking just about the physicians, but the clinical group. We need to buoy the system. We have the best healthcare system in the world. Can we keep it that way and make everybody happy within it?
Yeah, I love that. Dr. Rachel Hitt, thank you so much for joining Next in Q today. It's always a pleasure to chat with you.
Well, thank you so much for having me. I appreciate it.
Next in Q is brought to you by Happy To and is produced by me, Rob Dwyer. If you enjoy this podcast, please by all means subscribe and or rate this podcast in iTunes or your favorite podcast app. But more importantly, please tell just one person about this podcast. Word of mouth is the best way for people to discover new content. As always, thanks for listening.